In this podcast, I'm going to talk to you about Achilles tendon repair using the Aculon device. This is a device made by Integra, and it's minimally invasive, and it can be inserted using an incision only 2 or 3 centimetres wide. It's useful for acute ruptures within 2 weeks of the injury. It's a relatively quick procedure, it's very straightforward, and it gives as biomechanically strong a repair as any other. It uses a purchase on healthy tissue away from the stringy bits of tendon which don't allow any good hold using stitches. For this procedure to be performed, the patient is placed prone and their knee is flexed. I use a tourniquet. I give all of my patients a poppety or block so that they're pain-free when they wake up from their surgery. The incision is about 3 centimetres long, and it's a transverse incision rather than a traditional vertical incision. This means that there's less tension on the wound, and also it means that when the tendon is flexed afterwards, the wound tends not to gape, and in fact flexion of a tendon results in the wound being compressed. The incision is placed at the site of a defect. This can be located using ultrasound. After the skin's been incised, we find the paratenon and incise that. Our dissection then stays within the paratenon. We dissect proximally and distally within the paratenon to isolate the tendon. This can be held with some Vicryl stitches on either end so that this can be grasped while the Aculon is inserted. The Aculon device is plastic and it has 4 prongs. The inner prongs are seated within the paratenon on either side of the Achilles tendon. Needles are introduced through the outer pegs, and this will necessarily go through the inner pegs on either side of the tendon and hopefully grasp the tendon as well. We're grasping the tendon in healthy tissue, so we should have a good bite on the tissue. Here we can see the Aculon inserted, and 3 sutures have been inserted through the Aculon device, and you can see the end of the tendon prolapsing through the wound. The Aculon device is then pulled out. The sutures pull into the skin, and they can then be grasped within the paratenon on either side of the tendon. Just how strong a hold can be demonstrated because using that set of 3 sutures, I can actually lift the leg off the bed. The same procedure is applied for the proximal end of the tendon, and we then have 6 strands of suture on either side. We can then suture the strands of suture together. As you can see, with the foot plantar flexed, we achieve adequate shortening of the stretched ends of the tendon so that the foot achieves a plantar flex position. When the wound has been sutured, you can see that it's in the line of Langer's lines, which means that you get a good cosmetic result, and it also means that the wound isn't going to gape. At the end of the procedure, the foot is able to plantar flex, and Simmons test is negative. The dressings are going to be applied, and then an air cast boot is applied using 3 wedges. My rehab protocol is to use this for the patient to be fully weight bearing in their air cast boot from day 1. They go home on the day of surgery, but they use crutches for balance, and they're prescribed low molecular weight heparin. They can start performing exercises immediately, and this can be active with the foot being plantar flexed and then being allowed to relax back to a neutral position, but never dorsiflexed, certainly not for the first 6 weeks. They may find it difficult to actively plantar flex, and if pain relief doesn't help, then I encourage patients to manipulate their foot into plantar flexion so that the tendon is gliding. This will then decrease any adhesions with the paratenon. If the patients feel able to, they can get on an exercise bike without any resistance, and if they can get into a pool, they can practice deep water running, holding onto the side of the pool. There's no active dorsiflexion for 6 weeks. At 2 weeks, the patient's reviewed and the stitches can be removed. One wedge is removed from the boot, and this leaves 2 wedges behind. A further wedge is removed at 4 weeks and at 6 weeks, and when the patient feels comfortable walking in their boot, they can discard the boot and return to a normal shoe, but I advise them to use a 1 cm heel raise just to protect the Achilles tendon. From 6 weeks, they can start active and passive dorsiflexion, and then the physios can work on power and endurance, and I generally discharge my patients at about 12 weeks. I've done about 40 Aculon repairs, and in this series I've only had 1 episode of mild sural neuropraxia, which resolved. This is presumably because the needle penetrated the sural nerve as it was being inserted. I haven't had any ruptures or infections and no wound breakdown, and there haven't been any episodes of thromboembolism. There can be problem cases when the proximal hold is very flimsy. If this happens, then you can use a hybrid technique, and so use the Aculon for the inferior half of the repair, which is where you would expect the tension to be in any wound repair and ischemia, and where wound breakdown tends to occur because of bowstringing. And you can use a Krakow technique for the superior half and generate your sutures which can join to the Aculon sutures in the inferior half. And although the wound is extended, it means that you have a nice solid repair. So the advantages of the Aculon are that you can aim for early tendon gliding, the patient's fully weight bearing, the home on the day of surgery with a popliteal block, the risk of DVT is minimised. The wound complication rate is nil so far, and touch wood, it's going to continue. And I've only had 1 case of a transient sural nerve neuropraxia. I don't believe that the risks of surgery are as great as they were previously, specifically the risk of wound breakdown. And I believe that any patient, no matter what age, with an Achilles tendon rupture can be treated safely using the Aculon technique. I think that elderly patients, especially ones who are active, would actually benefit more from having a repair, so that they're fully weight bearing immediately after surgery, and this allows them to rehabilitate better. If you'd like further information on foot and ankle problems, then you can look at my website www.footanklesurgeon.com or www.manchesterfootsurgeon.co.uk.